Hello, and thank you all for taking the time to support myself and the other scholars in the presentation of our research. My name is Ashley Bland, and today I'll be presenting about a new medical device called the anti-slip patch. This research has been conducted under the guidance of Dr. Heidi Bell, who serves as assistant professor and undergraduate coordinator within the Human Performance Studies Department, as well as Sarah Nickel, who serves as director of WSU's Molecular Diagnostics Laboratory and assistant professor of the Medical Laboratory Science Department. The Iowa Oral Performance Instrument, also known as the IOPI, is a medical device created to measure tongue strength and endurance and is most often used in patients with dysphagia, often caused by neurogenic disorders such as stroke, Parkinson's disease, brain injury, and multiple sclerosis. The measurements taken by the IOPI assist with diagnosis and further guide and monitor a patient's treatment plan. It has been helpful to many since its creation in 1988, but it has had one common concern. When the bulb encounters saliva, it has the tendency to shift and slip within the oral cavity from its intended placement, which is shown in the photo on the left. Efforts to address this bulb slippage led to the development of the anti-slip patch as shown on the right. This patch has a latex-free surface that's textured and is adhered to the surface on one side of the bulb for the purpose of preventing the device from slipping. It's shown promising results thus far, and due to its ease of manufacturing and use, it has tremendous potential in industry. However, FDA-regulated usability and hazard risk assessments have to be administered before the anti-slip patch can be widely used and accepted. So for an FDA device to be considered safe, there must be valid scientific evidence that the probable benefits to health from use of the device outweigh any probable risks. So in order to follow this FDA definition, the objective of this study was to simulate a patient-like environment in order to examine microbiological content, adhesive residues, and microbiological growth. So to set up this study, a 25 milliliter tube of saliva was first gathered and tested negatively for COVID-19 for safety assurance purposes. After that, 27 IOPI bulbs were prepped across 3 different conditions. Condition 1 featured the IOPI bulb in its natural state, with no patch attached to it. Condition 2 featured the IOPI with an anti-slip patch attached and was labeled patch wash. And then condition 3 featured the IOPI with an anti-slip patch attached and was labeled patch no wash. Each bulb was then individually dipped into the 25 milliliter tube of saliva, then placed in its own tube to rest for a predetermined amount of time, which was 15 minutes, 30 minutes, or 1 hour. Once time expired, the bulbs were individually removed from their tubes, and the conditions labeled patch wash and no patch wash were cleaned with warm water and Dawn dish soap for 30 seconds, according to IOPI's pre-existing standards, then patted dry with a clean paper towel. After cleaning, or not, for the patch no wash group, each bulb was rolled onto its own sheep blood augers plate, which was then placed in a CO2 incubator at 37 degrees Celsius for 48 hours. This set of plates is referred to as batch 1. The bulbs were then placed back in their original packaging and placed in a box for 1 week. After the 7 days passed, they were removed from their packaging and rolled onto new sheep's blood auger plates. This set of plates is referred to as batch 2. Our experimental setup under the biological hood is shown in the picture below. In order to analyze our results, we conducted 3 separate repeated measures ANOVAs, or RMAs. 1 for batch 1, 1 for batch 2, and 1 for a comparison of batch 1 to batch 2. Significance level for each analysis was set to 0.05. The first RMA showed a significant difference in bacterial count between conditions. More specifically, the post-hoc comparison showed that the patch no wash group had a higher count of bacteria compared to the others. None of the other findings for this group were significant. The RMA for batch 2 had a similar report to batch 1, showing a significant difference in bacterial count between conditions. Once again, post-hoc revealed that patch no wash had a higher count of bacteria, and none of the other findings were significant. Now, when comparing batch 1 to batch 2, the patch no wash group was fairly equal, with both batches having greater than 100 colonies grown. However, when looking at the no patch wash and patch wash group, batch 2 actually had lower flora counts, which was unexpected since most bacteria thrive in moist, dark environments, which is what batch 2 was exposed to. So once more, the RMA showed that the group with the patch that had not been washed had significantly higher counts of bacteria. So this slide shows the previously mentioned bacterial plates on blood agar, As you can see by the number of colonies on each plate, the patch no-wash group had a significantly higher count of flora, while the patch wash and no patch wash groups were very comparable to each other. As previously mentioned, for a device to be considered safe according to the FDA, valid scientific evidence must be shown to assure that the probable benefits outweigh any probable risks. So in order to obtain this scientific evidence, this study monitored unnecessary risk and negative effects of microbiological activity and adhesive residues on the IOP bulb by simulating a patient-like environment. Overall, the findings showed that adding an anti-slip patch to the IOP bulb did not significantly increase microbiological risk with saliva exposure, and no residues were present from the adhesive. Due to this, the findings favor use of the anti-slip patch with the bulb because the only action that truly increases risk is improper washing techniques. So while the overall results favored the anti-slip patch, there are a few items to consider in future studies. First, variability of the raw colony counts were of concern. As you can see in the table in the bottom right corner, each group has trials 1, 2, and 3. These values per trial were different, which is to be expected, but the amount that they vary by changes per time period and group. This may be due to inconsistencies in the washing process. Even though a set process was described, some bulbs may have been washed more thoroughly than others. The second item to consider in future studies is the reason that batch 2 grew less bacteria than batch 1. The retest of bulb conditions across time was important because it simulated an unfavorable practice that doctors or clinicians might allow. A bulb is commonly issued to a patient and reused across multiple visits. So after the first office visit, the bulb may or may not be washed and then placed in a drawer to sit until the patient returns for their next appointment. This practice has the potential to invite an elevated presence of microbial colonies on the bulb when the patch is attached, since most bacteria thrive in moist and dark environments. This has the potential to heighten a patient's risk of illness. However, after removing the bulbs from the simulated dark and isolated environment, batch 2 actually grew significantly less flora than during the batch 1 plating. This was unexpected because most bacteria, as I've said, thrive in warm, moist, dark environments. So one hypothesis was that the anti-slip patch that we used may have contained antibiotics. And to test this, a rough copy of the patch was made, as shown on the left, and placed in the middle of a lawn of Staph aureus on a sheep's blood agar plate. As expected, a zone of inhibition grew around the patch on the plate, confirming the presence of some form of antibiotic. The picture on the right shows an example of a zone of inhibition with antibiotic, and the picture on the left shows the patch and the bacteria. So the overall objective of this study was to determine if the anti-slip patch added unnecessary risks or negative effects when used on the IOP bulb by simulating a patient-like environment. When evaluating microbiological content and adhesive residue, the anti-slip patch did not aid in the growth of bacteria on the surface of the IOP bulb, nor did it add abrasive residue upon removal. However, this version of the patch did contain antibiotics, so it is most likely not the best option for patients with an oral myofunctional disorder, and further studies will be required to evaluate the anti-slip patch without antibiotics. Here are my references, and at this time, I am now open for questions. We decided on 3 trials per condition because that's, first, pretty standard in the industry, but second, we wanted thorough trials to make sure that our results were consistent. So we had 2 different controls, the no patch wash group, which was the IOP bulb in its natural state, and then the patch no wash group, which was just free growth, basically. So with those 3 trials, we just wanted to make sure that we had all of our bases covered and getting enough data to properly analyze our results. Because we were honestly comparing the anti-slip patch to the IOP bulb in its natural state. So the IOP bulb now is already washed in its standard procedures. So there have already been studies done to see if people don't wash the IOP bulb in its natural state. So we really wanted to compare with the patch what negative effects may or may not have been added. That's a great question. So honestly, this started out as a genuine mistake. The box of materials that we used were very misguidingly labeled, and so we honestly grabbed the wrong one initially, but after further research, we found that this actually could be a possibility and use of the patch. We just need to evaluate the anti-slip patch with antibiotics versus the anti-slip patch without antibiotics, so that'll be a future study. Thank you for the question. That's a good question.